clinical or laboratory guided and intervention should be considered at an early juncture in all surgical and critically ill patients. Management of critically ill and injured patients is optimized with the use of evidence-based and algorithm-driven therapy. So we discuss metabolism during fasting. To maintain the basal metabolic needs, example is patient at rest and fasting. A normal healthy adult requires approximately 22 to 25 kilocalorie per day drawn from carbohydrate, lipid, and protein sources. In the healthy adult, principal sources of fuel during short-term fasting, and I mean less than 5 days of fasting, are derived from muscle proteins and body fat, with fat being the most abundant source of energy. The normal adult body contains 300 to 400 of carbohydrates in the form of glycogen, of which 75 to 100 grams are stored in the liver, and approximately 200 to 250 grams of glycogen are stored within skeletal, cardiac, and smooth muscles. So this is a diagram of the fuel utilization. Example, in a 70 kilogram man during short-term fasting with an approximate basal energy expenditure of 1,800 kilocalories. During starvation, muscle proteins and fat stores provide fuel for the host, while the latter being most abundant, which is the fat stores. So the liver has the glycogen, and the glycogen is turned into energy by gluconeogenesis, of which glucose is formed 180 grams, 140 of which is from the brain, 36 grams. That's how they get energy when they are fasting, a normal 70 kilogram person. In prolonged starvation, systemic proteolysis is reduced to approximately 20 to urine, and urinary nitrogen excretion is stabilized at 2 to 5 grams per day. This reduction in proteolysis reflects the adaptation by vital organs like the myocardium, brain, renal cortex, and skeletal muscles to using ketone bodies as a principal fuel source. In extended fasting, ketone bodies become the most important fuel source for the brain after 2 days and become the principal fuel store after days, by 25 days, 24 days. So this is the fuel utilization in long-term fasting man, 70 kilograms also. So they use muscle protein, and fat stores triglycerides. The muscle protein is turned into amino acid, while the fat stores is turned into glycerol and fatty acid. In the liver, in the kidney, they are produced into energy by gluconeogenesis, while in the liver, the glycogen is also turned into gluconeogenesis and oxidation. Then to glucose, then to lactate and pyruvate, which is the end product. Metabolism after injury. The magnitude of metabolic expenditure appears to be directly proportional to the severity of insult, with thermal injuries and severe infections having the highest energy demands. So here, major burn requires the most energy, while starvation without energy expenditure requires the least. Lipid metabolism after injury. Lipid metabolism potentially influences the structural integrity of cell membranes as well as the immune response during systemic inflammation. Fat mobilization or lipolysis occurs mainly in response to catecholamine stimulus of the hormone-sensitive triglyceride lipase, and oxidation of 1 gram of fat yields approximately 9 kilocalories of energy. So this is important pag itong binibigay kong this which are items which I'm giving to you is important when you later compute for the energy expenditure of the patient, surgical patient, because you will have to compute their parenteral nutrition later. It will be based on this. The 1 gram of fat is equivalent to 9 kilocalories. Then you will estimate the energy expenditures, example 1,800. You will multiply that, then divide again. If you compute for the parenteral nutrition of your patients later. Carbohydrate metabolism primarily refers to the utilization of glucose, and oxidation of 1 gram of carbohydrate yields 4 kilocalories of energy. In starvation, glucose production occurs at the expense of protein stores, and the primary goal for maintenance glucose administration in surgical patient is to minimize muscle wasting. So for fat, it's 1 gram yields 9 kilocalories. But for carbohydrates, it's 1 gram yields only 4 kilocalories. Glucose transport and signaling. There are two distinct classes of membrane glucose transporters in human system. First is facilitated diffusion glucose transporters or GLUTs that permit the transport of glucose down a concentration gradient. Sodium glucose the second transporter is the sodium glucose secondary active transport system, which transports glucose molecules against concentration gradient by active transport. So this, human facilitated diffusion glucose transporter family. So type 1, 2, 3, 4, 5 with amino acids and the major expression sites. So by particular in expression site siya. So for GLUT1, it's expressed in the placenta, brain, kidney, and colon. For GLUT2, liver, pancreatic B cells, kidney, and small intestine. For GLUT3, it's brain and testes. For GLUT4, it's skeletal muscles, heart muscles, brown and white fat. And for GLUT5, it's small intestine and sperm. Protein and amino acid metabolism. The average protein intake in healthy young adult ranges from 80 to 120 grams per day. And for every 6 grams of protein yields approximately 1 gram of nitrogen. The degradation of 1 gram of protein yields approximately 4 kilocalories of energy. So again, 1 gram of fat, 9 kilocalories, 1 gram of carbohydrates, 4 kilocalories, 1 gram of protein, 4 kilocalories of energy yield. Okay? After injury, the initial systemic proteolysis, mediated primarily by glucocorticoids, increases urinary nitrogen excretion to levels in excess of 30 grams per day, which roughly corresponds to a loss in lean body mass of 1.5 per day. An injured individual who does not receive nutrition for 10 days can theoretically lose 15% lean body mass. This is important for you to know kasi usually sa patients natin sa surgery, there are times in operation, depending on the operation, we do not let the patient eat for several days. So at least when you know this, you can at least approximate the body, the weight loss or the muscle mass loss of the patient. Para alam nyo kung mag-start na kayo ng parenteral nutrition or hindi. For protein catabolism after injury provides substrates for gluconeogenesis and for the synthesis of acute phase protein. So again, this is what I showed you earlier. Uh, for muscle mass expenditure for based on the injury of the patient. So major burns still has the most energy expenditure for the patient. Nutrition in the surgical patient. The goal of nutritional support in the surgical patient is to prevent or reverse the catabolic effects of disease or injury. The second objective of nutritional support is to meet the substrate requirements for protein synthesis. So here, in a normal state, the brain, the heart, the RBCs, lungs, immune system, they all give the energy by giving out glucose, but for the heart, it's fat and so on. So this is a example, energy expenditure for the day for the patient. So 1,600 kilocalories per day. So you can approximately give a parenteral nutrition equivalent to 1,600 kilocalories per day as well, depending on the injury of the patient. So this is the computation. So for how much protein? Protein expenditure is based also on the severity of the injury. So if the injury is very severe, the protein requirement of the patient is also going up. So you have to provide higher protein maintenance food for the patient. Caloric adjustment above basal energy expenditure in hypermetabolic condition. For normal to moderate malnutrition, kilocalories or per kilogram per day is 25 to 30. Adjustment above basal energy expenditure, 1.1. Grams of protein per day is 1, and non-protein calories, mainly in the form of nitrogen, is 150 over is to 1. And so on. For mild stress, moderate stress, severe stress, and burns. Pataas siya ng pataas yung kilocalorie per day. Ito yung i-compute ninyo times dito sa weight ng patient. Okay? So, pag ini-expect nyo is mild stress lang siya, 30 times the weight of the patient, 60 kilograms. Pero pag ini-expect nyo is burn siya, na mataas ang energy expenditure siya, 40 kilocalories per day, i-compute nyo siya 40 times 60 kilograms. Ito, ang lalabas, yun yung kilocalorie per day na expenditures niya, yun ang ipoprovide nyo by parenteral nutrition. Determine route of feeding. You can give feeding by enteral nutrition or by parenteral nutrition. Rationale for enteral nutrition. Enteral nutrition generally is preferred over parenteral nutrition based on the lowest cost of enteral feeding and the associated risk of the intravenous route, including vascular access complication. When we talk of enteral nutrition, anything by mouth. Kung na-feed nyo kaya nyo i-feed by mouth yung patient, the best way to feed the patient pa rin is by mouth. Una, kasi nagagamit niya na yung bituka niya, gagalaw na yung bituka niya. Second is maiiwasan nyo yung mga complications ng parenteral IV access, which I will tell you later. Of further considerations are the consequences of gastrointestinal tract disuse, which include diminished secretory IgA production and cytokine production, as well as bacteria overgrowth and altered mucosal defenses. Enteral formulas in general, feeding formulas to consider are gastrointestinal tolerance promoting, anti-inflammatory, immune modulating, organ supportive, and standard enteral nutrition. The functional status of the gastrointestinal tract determines the type of enteral solutions to be used. And factors that influence the choice of enteral formula include the extent of organ dysfunction, the nutrients needed to restore optimal function and healing, and the cost of specific products. So this is what we call enteral nutrition, anything by mouth. Either kakainin niya, magdadaan sa mouth, or pwede kayong, you can use an nasogastric tube. Mag-insert an NGT. Or by PEG. PEG is wherein we insert a tube directly to the stomach. So the food is directly placed into the tube going into the stomach. So dadaan pa rin siya sa normal route going to the small intestine, then going to the colon. So these are the options for enteral feeding access: NGT, nasoduodenal or duodenal tube, PEG or percutaneous endoscopic gastrostomy, surgical gastrostomy, fluoroscopic gastrostomy. Pare-pareho lang yung function niyan. They put the food to the stomach directly. Except the others are with incisions, some directly to the stomach. And these are the possible risk if you use the following option. Okay? Parenteral nutrition. Parenteral nutrition is the continuous infusion of hyperosmolar solutions containing carbohydrates, proteins, fat and other necessary nutrients through an indwelling catheter inserted into the superior vena cava. The principal indications for parenteral nutrition are malnutrition, sepsis, or surgical or traumatic injury in seriously ill patients for whom use of your gastrointestinal tract for feeding is not possible. The safe and successful use of parenteral nutrition requires proper selection of patients with specific nutritional needs, experience with the technique, and an awareness of the associated complication. The following are the patient groups for whom parenteral nutrition has been used in an effort to achieve this goals. For the newborn infant with catastrophic gastrointestinal anomalies such as TE fistula, gastroschisis, omphalocele, or massive intestinal atresia, infants who fail to thrive due to gastrointestinal insufficiency associated with short bowel syndrome, malabsorption, enzyme deficiency, meconium ileus, or idiopathic diarrhea. In adult patients with short bowel syndrome, secondary to massive small bowel resection. And when we say short bowel syndrome, we talk of patients who have less than 100 centimeter of the small intestine in the colon and the colon, or those which have less than 100 centimeter without colon or ileocecal valve, or less than 50 centimeter with intact ileocecal valve and colon. Patients with the enteric, enterocolic, enterovesical, or high output enterocutaneous fistulas. Those who with enterocutaneous fistulas giving out more than 500 ml per day output. Surgical patients with prolonged paralytic ileus after major operations, usually those who have ileus 7 to 10 days, those patients with multiple injuries or blunt or open abdominal trauma, or patients with reflex ileus complicating various medical disease. Patients with normal bowel length but with malabsorption secondary to sprue, hypoproteinemia, enzyme or pancreatic insufficiency, regional enteritis or ulcerative colitis. In adult patients with functional gastrointestinal disorders such as esophageal dyskinesia or anorexia nervosa. Patients with granulomatous colitis, ulcerative colitis, or tuberculous enteritis in whom major portions of the absorptive mucosa are diseased. Patients with malignancy with or without cachexia, Cachexia is severe muscle wasting in whom malnutrition might jeopardize successful use of a therapeutic option. 10. Patients in whom attempts to provide adequate calories by enteral feeding or high residuals have failed. So palagi nating ini-start ang patient by enteral if kaya nila. Pero pag hindi nila makaya, then that's the time we shift into our parenteral nutrition. We also give parenteral nutrition to critically ill patients who are hypermetabolic for more than 5 days or for whom enteral nutrition is not feasible. Now, these are the patients in whom hyperalimentation is also contraindicated. First, are patients for whom a specific goal for patient management is lacking or for whom instead of extending a meaningful life, inevitable dying would be delayed. Patients experiencing hemodynamic instability or severe metabolic derangement require control or correction before hypertonic intravenous feeding is attempted. So we have to correct first the problem before giving our parenteral nutrition. We just don't give it right and left. Patients also for whom gastrointestinal tract feeding is feasible, in the vast majority of instances, this is the best route by which to provide nutrition. So if they can use the mouth, why give them parenteral nutrition? You use the mouth for them to use the gastrointestinal tract. Patients with good nutritional status, you do not need to give them your parenteral nutrition. Infants with less than 8 centimeter of small bowel, because virtually all have been unable to adapt sufficiently despite prolonged periods of parenteral nutrition. 6. Patients who are irreversibly decerebrate or otherwise dehumanize. So this is how we give our parenteral nutrition. We either give them directly by giving a perm cut, by putting a permanent catheter directly on your aorta going to your heart. Then it will flow to the blood. Sasama na siya. Another one is through your basilix, peripheral central line, central percutaneous insertion. We use usually a bigger tube for this. French 8 feeding tube. For because the problem is if you insert a small catheter here, it will be clogged and it will cause phlebitis on this part of the venous supply of the patient. Total parenteral nutrition, also referred to as central parenteral nutrition, requires access to a large diameter vein to deliver the entire nutritional requirement of the individual. Peripheral parenteral nutrition is the lower osmolarity of the solution used for peripheral parenteral nutrition, secondary to reduce levels of dextrose and protein, allows its administration via peripheral vein. So these are the complications of your parenteral nutrition. So you should be worried when you are giving food by parenteral way, the parenteral way. For the technical complications, we have sepsis secondary to contamination of the central venous catheter, pneumothorax or air outside of the lungs, hemothorax or blood outside of the lungs, hydrothorax, subclavian artery injury, thoracic duct injury, cardiac arrhythmia, air embolism, and catheter embolism, cardiac perforation with tamponade. So, before giving outer parenteral nutrition, you should always check if the tube is still inside or if the patient doesn't have symptoms for injuries like this. For the metabolic complications, we have hyperglycemia may develop with normal rates of infusion, in patients with impaired glucose tolerance or in any patients if the hypertonic solutions are administered too rapidly. Excess feeding also has been related to the development of hepatic steatosis or marked glycogen deposition in selected patients. Next is cholestasis and formation of gallstones are common in patients receiving long-term parenteral nutrition. Next is intestinal atrophy. Because you do not use the bowels, the small intestine and the colon, we have the intestinal atrophy. The intestines become small. Lack of intestinal stimulation is associated with intestinal mucosal atrophy, diminished venous height, bacterial overgrowth, reduced lymphoid tissue size, reduced IgA production, and impaired gut immunity. So this is the feeding algorithm. You first check if the patient can tolerate enteral feeding or not. If the patient can tolerate enteral feeding, then you feed him by the mouth or by tube, more than 3 to 4 weeks. If in 3 to 4 weeks the patient cannot feed and yet, then you can change the feed NGT into a gastrostomy or jejunostomy tube because these are easier to manage. But if the patient cannot tolerate feeding by mouth, you put parenteral nutrition. For short term, we use the peripheral, the Basilix. But for long term, we use a central parenteral insertion or the firm cut, permanent catheter. So this is another algorithm for preoperative phase feeding of the patient. You just need to take note of the enteral access as well. For surgical nutrition pathway, preoperative phase. So assess nutritionally, normal to moderate malnutrition. If the patient has normal to moderate malnutrition, you can go ahead with your surgery. But for severe malnutrition, like especially if the patient is going into esophageal resection, gastrectomy, or pancreaticoduodenectomy, or what we call the bypass for pancreatic mass, you should give your parenteral nutrition plus omega-3 fatty acid plus antioxidant before doing the surgery. Okay? So that ends the lecture. Did you get? Do you need? Actually, these are all in the Swartz. In your Swartz. Do you have your Swartz? It's all in the Swartz. You just need to read them. Okay? Then the president, please inform me at least 1 week